All right, so it's Thursday, July 1st. We're going to start with thorax right now. So we're going to review and come back to talking about PNF. That's where we left off with this before I had that wonderful day of migraineness, which those are two lessons that were kind of easy for doing that day because they weren't in depth as this. So when we last left, we had talked about kind of the irradiation type topics, which I did review in that the review session we had. So that if you're lost on irradiation, please make sure you check that out. I also talked about myotatic and inverse myotatic in the review session. So again, if you're lost in that, please check the review session out. The last thing we had finished with were the 4 patterns, right? The 4 diagonal, hence D patterns. 2 of the upper extremity, 2 of the lower extremity. And if you remember, I said that those diagonal patterns are going to be named in, so you have D1, D2 of the upper extremity, D1, D2 of the lower extremity. Each of those are going to have a flexion and an extension pattern. When we're talking about D1 flexion or D1 extension or D2 flexion or D2 extension, what joint determines whether we're talking about flexion or extension? Do you remember? Of the upper extremity? Good guess. The shoulder. Good. Right. So remember that no matter when we're talking about it, the pattern is named for the most proximal joint segment. So the shoulder for the upper extremity, the hip for the lower extremity. Right. So when I'm going into D1 flexion and coming up and across my body, my shoulder technically is going into flexion, right? I'm coming up and across. When I go into D1 extension, I'm going down and out, and my shoulder is going into extension. That's how they're named. I've got to tilt my camera down some here. I don't have my nice setup that I have at home with multiple cameras. Right, so an extension pattern goes out this way, flexion pattern comes up and across this way. So it's of the shoulder itself. Now, all the other joints have components of movement, but the patterns are named for the motion at the proximal joint segment, right? So that means if we're talking about D1 and D2 of the lower extremity, which joint is going to be naming the direction? So shoulder of the upper extremity, it's the hip of the lower extremity. Good. Now, does that mean that the pelvis doesn't move along? No, the pelvis has some motion too. Same thing with the scapular girdle, right? The shoulder girdle. But the true joint we're going to go off are those 2 big ball and socket joints, right? So remember I talked, and maybe you don't remember, but I talked that the D1 pattern, so diagonal 1 of the upper extremity, what did I tell you the nickname to remember it is? Or what are some of the terms I told you to remember it for D1? Eat the apple. Good, right? Right? Or I told you in OT, that's D2. Amanda, that's D2. We're going to cover that next. In OT, that's okay. That's why we're reviewing. Don't ever be afraid to make answers, please. Right? Anthony makes us fool of himself all the time. I mean, just kidding. He said I didn't call him enough, so I'm going to keep calling on him. So what did I say that OT calls it? Not necessarily eating the apple, but what did I say they nickname this pattern? So it looks like you're doing what?
Isn't it throwing away the apple?
Yeah, throwing away the apple and eating the apple, right? They nicknamed it the self-feeding pattern because it looks like you're feeding yourself, right? And again, OT is concerned a lot with that, with feeding, right? That's an ADL. So they tend to call this the self-feed pattern in OT. We just call it whatever you want, right? Whatever helps you remember it. So we've got the apple coming up and we're eating the apple. That is our flexion pattern, coming up and across. And then our extension pattern, we're going down and throwing the apple away. Up and across, down and away. Up and across, down and away. Why do you think I'm using those terms right now? Why do you think I keep saying up and across, down and away?
So that we cross midline.
Good. Yeah. And those are also the cues you're going to use for who?
For our patients.
Patients. Yeah. Right. Up and across makes sense down and away makes sense. They're very simple commands that once you show them how to do the patterns, you can do them, right? So what I'm going to do when I have a patient is I'm going to walk up to them and say, you know, we're going to do some motions with you today, right? And we'll just start, and I mentioned this in the study session. As far as this is concerned for you guys going out to your clinics, you don't have to be experts at PNF. What I would expect you guys to be able to do is do the patterns passively with a patient, right? So be able to move them through the patterns passively. We will add resistive patterns in the future, and we will also add some kind of muscle energy techniques in the future as well. So you should be able to basically move them through the patterns. You're going to, you know, if I'm working with Jason, I'm going to come up to Jason, you know, Jason, we're going to do these. It's kind of funky patterns, right? You don't have to call PNF because I say PNF to a patient, they're going to be like, what? Right? So we're going to move your arm through some certain patterns. And what it's going to look like is I'm going to take your arm from out here, bring you up and across, and then I'm going to take your arm down and away. I have now done what? I have shown them, right? Let me see. Okay, go ahead and lay back, Jason. I'm going to move your arm through. So now I'm telling them this is the way we're going to do it, right? And if it's just passive, they don't even have to do anything, right? They're just going to relax. That's the do they're going to do. Relax and watch your hand move through the motions. Right? Good, good. And we're just going to let them go watch that motion kind of going through it. We're going to add resistive later, but then we would have them do it if we're going to add resistive to it. Right now, not so concerned about that. So that's the D1 pattern. And again, there are all these motions associated with it. For your boards, you do have to remember what each of the patterns are, where shoulder is. I'll be 100% honest, the hand and the feet are very rarely asked on your boards, but the shoulder and the scapula, so the shoulder and the scapula, the hip and the knee, no, let me think. Mainly just the hip and the PNF patterns of the leg are asked on your boards. So let's say that, you know, you are performing, your patient Truman is in bed and you are performing D1 flexion of the upper extremity patterns. That's the coming up and across. What is your final position of the shoulder, right? And so you're like, oh, I'm coming up and across here, right? So I'm flexed, I had already said that, right? I'm also adducted because I'm across the body. And if I bring this out to the side, I'm technically externally rotated, right? It's just bringing it across in horizontal adduction. So what I would do if I was getting a board question, because I just covered all these again with the other group that's out on clinic or getting ready to go for their boards. When you see a question, do the pattern. So what does UR and DR stand for in the scapula? Good question, Riley. Any guesses? Upward, good. Upward what? Rotation. There you go, good. Right, because when I come up, that scapula's got to rotate up, right? That 2-to-1 pattern. Or I can't get up here. That's where that kind of comes into play. So eat the apple, throw it away. Eat the apple, throw it away. Again, when we get back and we start practicing this, the first thing we are going to do as a group is literally, we're just going to do the motion. We're going to move somebody through just this general motion. We don't even care about hand position. I don't care about technique. Right, so Bianca is like, and this was one I struggled with the same. You have to look at the position of that humeral head, right? So that's why I said when I came up here, if I move this out of my adducted position, I'm externally rotated. Last page pattern for the shoulder. Yes, sure. I mean, I kind of do them simultaneously, so it's really hard for me to say it's the last pattern. But I guess, yeah, theoretically it would be. That's the one I'm getting. So Bianca, so one thing, when you're doing it, right, they all kind of happen together if you're doing it quickly enough, right? But when you guys first get to practicing this, I guarantee you guys are gonna be like, okay, so it's gonna take you a little bit to go through it. It's not gonna be as smooth. But the internal and external rotation got me a lot as a new grad and new student as well, because I'm like, well, this kind of looks like I'm internally rotated because I'm across my body. Right. Okay. Yeah. But again, and that's a great point, Anthony. So I feel like D1 flexion is you're pounding your chest because it's internal rotation, right? But again, it's not where this is. It's where my humeral head is. See, sometimes you learn something from me. I appreciate that. I appreciate it. Truman said he learned something from me about internal external rotation. I appreciate that. So you got to think about the way the humeral head is. That's what determines internal versus external rotation, not necessarily the way it looks. Right? So that's why when I broke this one down, what I did is I'm like, okay, so this is my final thing. I'm going to take myself out of adduction and look where I'm at. If I take myself out of horizontal adduction and adduction, I'm externally rotated, right? That's external rotation, internal, external rotation. If I just bring this across, I'm kind of in D1. Does that make sense? And then when I come down and I'm extension, right? So I'm out here. If I was to just adduct my shoulder a little bit, do you see where I'm at? I'm in internal rotation. And man, that shoulder's tight. So what I would say to you guys for this is just for this part of it, study the motions, but in reality, I'm not expecting you to be perfect. I'm not going to be expect you to know, oh, well, I don't know. If I ask you about wrist, flexion, or radial deviation, do the motion. It makes sense when you do the motions. And then you can guess off of it. That's the thing you guys got to think about. And the hardest one, and those are the big ones, and because if Bianca and if a couple of other you are confused on the internal external rotation, you better believe that's going to be one of the questions you're going to get, right? Because that's a confusing topic, which would be an easy one to write a question about, which would be mean. Those are the questions that pop up on the boards. Those easy mean topics. And Riley's going to start throwing stuff at me. So that's D1. And then I think it was Amanda that mentioned that she had started going on the D2 topic, right? D2 is drawing the sword. So you start across the body here. So up and out, down and in. Up and out, down and in. And I challenge some of you guys that go to the gym, try some of these patterns holding a weight and see if you don't feel them working more of your arm and shoulder than you thought you actually could work out in the gym, because it does feel different. And you also look kind of crazy doing stuff like that with the weight, but it feels different and it feels more functional when you're doing it. You still think about the glenohumeral when it comes to D2. You're exactly right. No matter what, it's always going to be named after that shoulder joint. So coming across like this, I'll cover that in a second. That was one of the things I wanted to review, John, because I knew that was going to be the next question. So this is D2 extension, because if I could keep going, I would go past my body and go back into extension, but my body's kind of in my way. Versus D1 or D2 flexion, because my shoulder is now up into flexion. Ta-da! Right? That one you could call drawing the sword. You could call it Saturday Night Fever. Staying alive, staying alive. I don't know. Whatever helps you remember that one. Either of those is valid. So then John asked a really good question, which was perfect to kind of lead in, is why at the elbow does it say flexion and extension? Well, the reason for that is because technically by the PNF patterns, you could theoretically do the whole pattern locked in extension if the patient doesn't have elbow motion. Because those are uniaxial joints, the elbow and the knee, those are ones that we consider that they might lose more frequently that motion. So if they're missing that motion, we can still do the pattern with a locked arm. Or if we're in contraction, I can still do the pattern even with a contracted arm. It doesn't limit me, right? But if we go back here to D1, there definitely is a preference, right? So when I go D1, when I'm out here, the preference is elbow extension in extension and elbow flexion in D1 flexion. And then in D2, right, the preference is flexion in D1 extension, D2 extension, extension in D1 flexion of the elbow, not the shoulder. And the knee is exactly the same. When we talk about the knee kind of follows that shoulder or that elbow because, again, those are uniaxials and we're always worried about those losing motion.
Mr. McKeever, could you go over D2 flexion and extension again?
Sure. So D2, right, we're going to start over here with our hand on the sword hilt, right? So I got my sword. I'm going to come up, right? I'm going to come up and out and cross. So I'm going up and out. I'm going to rotate over into supination, open out, and open my fingers up wide. And again, it's going to make more sense when we actually get hands-on with this. But that's the general motion. And we're going to practice these motions a little bit.
So in D2 motion of the upper extremity, you're starting in D2 extension.
What? So that's what that was. Look, you guys are reading my mind. I'm scared of this. Get out of my head, guys. I know there's free rent up there, but stay out of it. They're named after the direction you're going. I don't necessarily have to start here. I just naturally started here because I've done it so much. I could theoretically just start here and just go up here and just bring it down across the body and not even do D2 extension. If the only thing I'm working is flexion, I theoretically could care less about the extension if I'm not working it. My theory on that is, well, why not get both and get something out of both of them if I'm doing it, right? That's kind of my thought process on it. I have to come back down this way anyway to kind of reload. I might as well get a little bit of both going on. So when they're named, when you're like, see them on your, like if you see them on your flow sheet for you to do with the patient, right? Most times it will, where's my little cursor at? There it is. It'll say D1 flexion pattern of the upper extremity. At that point, you don't necessarily have to do the extension pattern, right? So you could just do up and across, self-feed, right? If you're doing both, it will say D1 flexion and extension of the upper extremity. And at that point, you're focusing on both. And for like a stroke patient, it'd be really good to focus on both. But maybe we're working with a overhead athlete, like a volleyball player. And what we're really trying to get is get some kind of extra range of motion out here at full flexion so they can reach overhead to serve or something like that. We may only work that D1 for that flexion portion. Does that make sense? Did I lose you? Okay, cool. All right. So again, those are the upper extremity ones. Okay, scapular motion of these. Okay, thank you, Anthony. I appreciate asking a question. So the scapula, here's the thing about the scapula. Don't get too lost in the weeds with the scapular motion, because in reality, in true reality, the scapular motion is just what occurs naturally with shoulder flexion. So I feel like in flexion, so are you talking about the D2 here, right? Is that the one you're talking about, Anthony? Okay, so with my flexion pattern, right? I'm coming up and out. So it's saying that my scapula is going to elevate. You understand that part? It is elevating, right? It has to upwardly rotate in order to allow me to get into flexion. That's just two kind of natural things that occur, right? Abduction, remember, with the scapula's, oh my God, be quiet, S word. Adduction, the scapulas go this way. Adduction, the scapulas go this way. It's away from the core of the body. It's the wings of the scapula, not the inside of the scapula, if that makes sense. So it's out here in the tips, the way they go versus, so you can think of when you do adduction of the scapula, it's more like protraction versus abduction of the scapula is more like retraction. Yeah. Right. Now, again, that has to do with the way the because retraction also has to do with pulling straight back as well. So it's not pure just retraction, but that they tie in together. So if I'm doing protraction, my scapula is going to adduct. If I'm doing retraction, my scapular is going to abduct. Does that make sense?
Yeah, that makes sense, but can you show me the flexion D2 motion again?
Sure. Flexion D2 motion from here, up and out and back.
Isn't your scapula protracted right now?
Protracted is here. I'm punching forward. Retract is when you do a row.
That's why I got confused. Thank you.
Okay. Yeah. Yeah. So remember, protraction is punching, right? Retraction is row. That's the way I always remembered them when I was in school. Right. So here's retraction, protraction, retraction, protraction. Does that help? Nods. Yeah. Okay. All right. So we have self-feed, drawing the sword and throwing away. Those are the two patterns. That's as hard as they get. We had just started talking about the lower extremity when we kind of finished last time. And the lower extremity patterns are the ones that I think are the hardest to do. They're a lot easier to do when the patient is supine. But here's the reason I'm going to say these are hard to do. Because what you guys don't realize, because we haven't really got hands-on with people yet, and we're going to, this is one of the things you're going to realize, legs are heavy. You guys will fly through upper extremity motions, no problem. But legs are heavy, right? My legs are probably 80 pounds each. And so if Diana's in there moving on my legs, doing PNF patterns with me for 30 reps, she's going to get exhausted from doing that. Just from doing that type of motion. She got swole too, but she's going to get exhausted from doing that. So I'm going to teach you some techniques that I use when I'm doing leg PNF to use my body as the fulcrum as I'm moving through the motion with the patients in order to save you from having to do as much upper extremity lifting. Because again, we lift everything with upper extremity, we're going to get tired quick. I'm going to show you the same thing with stretching, because there are some stretching techniques you can do where you use your own body to stretch the patient rather than, you know, straight holding their leg over their head or something like that with your hand. Because, you know, especially if you got somebody like Anthony who's kind of tall and you put somebody that's kind of tiny with him, to do some of these motions, you know, it gets a little difficult because his legs are going to be longer. Right? And so those are going to come into play. We had a student in cohort, I want to say it's cohort 5, but it may have been cohort 6, that was 6'7". And he was like 6'7", and 6 foot of it was his legs. I'm just joking. It wasn't truly 6 foot, but his legs were super long. And I kind of made everyone do PNF with his legs, because if you could do PNF on his legs, you could do it on anybody. You can get an extra person to help, but I'm actually going to show you techniques, Riley, that you won't have to, even with a really heavy person. And then I'm going to bring Dr. Avreskin in to show you some other techniques that she does, because she does some other techniques that, so, you know, Dr. Avreskin, and I liken this because it's funny. I liken our techniques differently. I approach things from a martial arts perspective. So when I'm doing PNF, you're going to find I'm doing a lot of kind of moving on the balls of my feet, moving on the heels of my feet, and sliding with my feet. Dr. Avreskin does very dance-like motions when she's doing PNF in order to conserve energy. But, you know, Riley, her technique may work better for you than my technique, or my technique may work better than her technique. That's why we have 2 people for this, is because that way you can see 2 different techniques. And maybe you have a technique in between them both. Great. There's not one set way to do them as far as body mechanics. And then ultimately, we're going to get into resistive, where then you're just going to get exhausted. It just, well, Dr. Avreskin will tell you, working with dancers and doing resistive PNF, and I worked with football players, good Lord, you will just exhaust yourself after, like, literally after 10 reps of the lower extremity with like a linebacker, sweat is just rolling off of you because they've got big honking legs. They're not like Truman. All right. I'll show you all. So so again, I'm going to go back to the upper extremity, right? So D1, upper extremity, eat the apple, throw it away. D2 upper extremity. Draw the sword, throw it away. We seem to be throwing a lot away. D1 lower extremity, I remember as kick the hacky sack. And D2 lower extremity, I remember as pee on the fire hydrant. Those are my ways of remembering it. Now, Dr. Reskin's like, well, this is kind of like a river dance. I think river dance is more like D1, but she seems to think river dance is more like D2. And I don't know how much you guys know about Irish people, but no one dances like that in Ireland. So I'm going to step back so I can get some range here, right? And I'm going to do them standing, and I purposely put shorts on so you can kind of see the way the foot's moving through it. So D1, can you guys still hear me from back here? Is this microphone still picking up?
Yes.
Cool, okay. It's not my nice microphone, so I gotta make sure. So D1, I'm gonna bring my chair over here for balance. So D1 is gonna start down and out and come up and in. So it's like you're coming up in and kicking a hacky sack and then going down and out. Boom. So with D1 flexion, right? I'm talking about flexion of the hip. My hip is coming up into flexion. It's coming into adduction and external rotation. Typically in D1 flexion, the knee is going to match. So I'm going to be flexed. But again, if the knee is fused, you can do an extension. My ankle is going to dorsiflex and invert. And my toes are going to extend. And then I'm going to go the opposite way. So my toes are going to flex. My ankle is going to plantar flex, evert. My knee is going to start extending. My hip is going to start extending. I'm going to abduct and internally rotate when I come out here. In, out. And this is the one thing I said to you guys briefly when we talked about this, was with the lower extremity, as the foot goes, so does the leg. So if I move my foot up into that dorsiflexion and inversion, the rest of the leg kind of comes with it. And then if I move it into plantar flexion and eversion, the rest of the leg goes with it when I'm doing D1. It's amazing. And when we do it the first time, you'll see what I mean. So then I'm, again, hacky sack. So I start out here, come up and in, down and out, up and in, down and out. Does the general motion make sense?
Yeah.
That's not to be confused with general disarray. That's a South Park character. No? No South Park people? Okay, fine. All right. So D2, peeing on the fire hydrant. So if with D1 I started out here, D2, and maybe I have to step back some more. I start across the body. So I'm going to go up and out, down and in. Right? So I'm going to flex my hip into flexion. I'm going to abduct and internally rotate. I don't have a lot of motion there. My knee is going to flex it there. My ankle is going to dorsiflex, evert, and my toes will extend when I'm way out here. And then I'm going to come down and in. So I'm going to extend my hip, adduct, externally rotate, plantar flex, invert, and flex my toes. So again, looks like I'm peeing on the hydrant, coming down and in. So that is a great question, John. So John asked, I'm assuming we couldn't do these with total hips and total hip arthroplasties, total hip replacements. We could, as long as we watch those precautions, right? We just are limited in what we can do, right? We wouldn't cross midline, we wouldn't internally rotate, and we wouldn't hip flex past 90 if we had a patient that had a posterior, right? We wouldn't go past neutral, we wouldn't abduct, it wouldn't externally rotate if we had somebody that had an anterior. Long story short, yeah, I would avoid them if I had a total hip replacement. we could, it's just going to really restrict the motion. And so if your PT asks, and that could be a thing. Maybe your PT tells you to do, D1 flexion of the hip after post-op, posterior hip. That might be a good time to go, hey, just real quick, are you sure you want me to do that? Because some of that's going to violate their hip precautions. And the PT just may go, oh, duh, I didn't even think about that. Yeah, you're right. Let's not do that. Let's just do the motions in general until the doc lets us go into PNF. Right. When we're doing PNF in PROM, the lower extremity, what position are they all in? Typically supine. Almost all of PNF is going to be done in supine, unless we're doing active.
So do you have them so some of the positions obviously go into extension. So do you just not go into extension, or do you have them kind of towards the side?
Yep, I move them over to the bed. So one of the techniques I use for this is if you were my patient, Riley, I'm going to put my hip right up against the side of the mat. And I'm going to tell you, okay, slide over until your hip's right against mine. That gives you a good feeling. And what that does is when I'm doing the motions then, and I'll show you because I can just glide through the motions, it makes you feel like you're not going to fall off the mat, even though we're going past the mat. And it still gives you that ability to do extension. So yeah, we're going to bring them all the way over to that edge. Same thing with shoulder, right? I can kind of cock them with the upper extremity, the body, kind of turn them, what we call on the East Coast, cattywampus on the mat so that their shoulders kind of off the mat so I can get some good extension going on, right? And they don't feel as much off balance. It's the hip ones that they kind of feel really awkward when they're going off that mat. They feel like they might fall off the mat. And that's where you build that trust with your patient saying, nah, fam, I got you. Don't worry. Waiting, John.
Oh, sorry.
Yep.
Thought you weren't done. Could you, if you're done,
Okay.
could you kind of go over the control the foot?
Yeah. So what I was talking about, what I'm saying there is, so let me see if I can demonstrate here. So if I'm up in here, right, into D1, if I evert, plantar flex, and flex the toes, as I do that and I push them into that motion, that almost starts pushing me out to this motion. And same thing when I dorsiflex, evert, and extend the toes, that lends to me doing this motion.
Mr. McKeever, sorry.
Yep.
When you said evert, I thought when you moved your foot, I thought it was you moved your foot into inversion. Is it inversion when you're the pinky toe of your side, your lateral side goes down? Yeah, isn't that inversion?
That's yeah. Did I say eversion? I'm sorry.
Yeah.
I was going out into eversion here.
Okay. Yeah.
Sorry,
so
maybe
that's invert. Okay.
Yeah, inversion.
I just was making.
Inversion, my toes kind of come in. Eversion, my toes go out. Yes.
Got it.
Maybe I botched that. I apologize if I did. I think I was trying to say I start up here in inversion, right? Because it's really hard to hold myself up here like this. So as the foot goes, right? So flex my toes, plantar flex my foot, evert my foot. As soon as I evert my foot, I actually started going out into that motion already. It's going to lead me to go out here. And then if I dorsiflex my foot, invert it, and pull my toes up, it leads me to come up and then across. Does that make sense, John?
Yeah, that makes sense. Thank you.
The hands, not so much. Theoretically, it should work the same with the hand. That if I'm up here and I'm closed, if I open up and go kind of this way, it leads me to go back here. But I find for some reason, the hand doesn't work as well as the foot does for motion. So that's why when I'm doing the Ds of the lower extremity, I really concentrate on cutting, getting that ankle to move the way I want it to move. And as that ankle moves, the whole leg moves with it. Any questions? Are you lost on any of the motions? And again, not perfect, just generalized motions. You can memorize all these later. but the generalized motion themselves. And now, like question, because Riley brought up what position would you do this in? Typically supine. But what if I have a patient that can't do it in supine? Could I do it in seated? Sure. It's just not going to be as effective. Yeah, and we're going to do that the second week, Diana. So like first week is going to be the basic exercises. Second week, we're going to do PNF. So don't worry. Oh yeah, we could do sideline, sure. I never thought of that, but yeah, absolutely. I could do sideline. It's going to be a little bit more straining on me because I've got to lift their leg up into the air, right? But you could. I don't think I've ever thought of doing it that way. I have to really think about my body position for that. Upper extremity, yeah, upper extremities would be easier, right? But now you gave me a challenge because now I'm trying to figure out how I would position my body in the diagonal. Yeah, upper extremities is definitely easier than lower extremities. But I'm now just trying to think of how I would position myself in the diagonal to make it easier on me. So I may have to try that. See, you got me thinking. It's interesting. But upper extremities I can easily do in seated, right? That's not that hard. You saw me demonstrate them seated. It's a lot harder to demonstrate the lower extremities than is the upper extremities by myself. All right, so there's some pictures kind of showing the general techniques for the lower extremities. Please watch the two videos that I have linked on, or the videos for the upper extremity and lower extremities, because they do resistive PNF. So she's providing resistance as the patient's doing it. But I think if you see and watch those videos a couple times, you'll kind of get the motions in supine. So when we're talking about techniques, when I said we're going to do basic PNF, which is just the passive range of motion, right? The very most basic form of PNF. Passive range of motion for PNF. Where is my little cursor? There it is this technique here called rhythmic initiation. When you hear rhythmic initiation, I want you to think P-ROM. That's just a fancy term that we can get around billing with the, what do you call it? The insurance companies. Passive range of motion is rhythmic initiation. Excuse me. Now, if you look here, remember I said the patterns are one thing, but look at all these different techniques that actually exist. That's a lot of stuff. Does anyone else feel a little intimidated looking at that? Like that's a lot of stuff there, Mr. McKeever. What do you doing for us, right? The good news is the names coincide with the techniques. They are fairly commonplace, right? Why I say that, reversal of antagonists or slow reversal, right? That's going to be a movement-based technique where you're going to reverse your resistances as the patient does it. Repeated contract, repeated stretch. The patient's going to do a contract one way, maybe a stretch the other, and then a contract that way and a stretch the other. They're named for what they do. The two ones that don't make a lot of sense are these two here, and I'm going to talk about these in a second when we get the definition of them. These two are the only ones that really don't make a lot of sense because their names, well, they make sense once I explain it. Their names don't exactly lend to describing them right off the bat. Combination of isotonics means you're doing what type of contractions there?
Eccentric and concentric?
Yeah, eccentric and concentric. That's all it means. It just means that when you're doing the motions, they're going to be doing a little bit of concentric and a little bit of eccentric motion. And again, each of these have definitions coming up. I just kind of want to, when you're looking at these going, you get a board question, you get a question on my test, and it says, reversal of antagonist. You're like, oh my God, what the heck, Mr. McKeever? Well, reversal of antagonist is just reversing the muscle that's resisting the motion, right? So maybe I'm moving you out into D1 extension. You're going to resist me moving you out that way. And then I'm going to passively move you back up into D1 flexion, and you're going to resist me by pulling the opposite way. You're going to antagonist. You're going to antagonize me. You're going to resist me moving you. Versus the combination of isotonics where you're actually going to be moving through the motions. But we'll talk about each of these individually here. So don't totally freak out yet. Diana, don't break out the pitchforks yet for me, please. All right, so rhythmic initiation. When you think rhythmic initiation, think mobility and think passive range of motion. Now, it's used to promote and start movement. Rhythmic, starting a rhythm or initiation, starting a rhythm of the night. I mean, of the shoulder, of the hip, of the elbow, whatever it may be. You're passively moving the patient through the available range of motion. If they only have this as my available range of motion, that's what we're going to move through. We're not trying to stretch them into a new range of motion at that point, right? We're just trying to keep what they got and lubricate the joint a little bit because motion is lotion. Helps the patient understand the diagonal patterns. So when I first start, let's say I'm working with, I'm working with Sydney on this, and Sydney's my patient. When I first start PNF with Sydney, I'm going to start off with rhythmic initiation. Doesn't matter what other pattern I'm going to do with her, because that way I can show her the patterns. This is what we're going to do. Just watch as I move you through these motions. I'm going to move you through these motions, right? That builds that memory up. She starts getting that cognitive stage going. And then when I ask her to do it, she builds up that cognitive stage further. So why might we do rhythmic initiation? Well, the patient has problems relaxing because the whole point of rhythmic initiation is relaxation. If they're hypertonic, and so remember, hypertonic can have a couple different kind of meanings, right? What is the difference between a spastic person and a rigid person? Does anyone have any ideas?
Spastic, does that mean that they're having like a lot of continuous jerky movement?
Good. And rigid is no movement. Good. Excellent point, Diana. So, right. So you guys are right. Bianca even said spastic is like spasm. So spastic movement is going to be kind of herky-jerky all over the place, right? There are a couple different types. The two main types of rigidity. Anyone have, did Dr. Sokel talk to you about the two types of rigidity? Usually contraction does lead to rigidity. Yep, Amanda, yes. There are two main types of rigidity that we deal with in physical therapy. So we have lead pipe. And we have cogwheel. So let's start with lead pipe rigidity. What do you think lead pipe rigidity feels like?
Stiffness.
Yeah, you're trying to push and nope, 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 nope. There's no spasming going on. It's just like a rock you're pushing against, right? You may get somewhere and then it locks up again. You're like, oh my God, this is rough, right? Versus cogwheel. What is a cogwheel? If anyone watched Jetsons, this was in Jetsons, but I think Jetsons is before all your time. So wheel with bumps, right? Do any of you have aviator type watches with the little gears inside your watch? Right? Those gears are called cogwheels. And so if a patient has cogwheel rigidity, it looks like that when you're moving them. So you get some areas of free motion and then it locks. And you get some areas of free motion and it locks. It's like you're turning that dial of the cog. So one of the patients that gets both of these kind of techniques is Parkinson's. Parkinson's tends towards lead pipe rigidity, but they can also get some cogwheel rigidity as well. And that kind of makes sense, and we'll talk about Parkinson's being a dopamine problem. That would make sense because dopamine is a relaxing neurotransmitter or hormone. And so if I'm super hypertonic, I'm not able to relax enough, right? So dopamine would help that. But it's a lead pipe, you're pushing on it, and it feels like you're literally pushing against a lead pipe. It's not going anywhere, right? You may get some motion, and then it's back to just not moving. Maybe get an inch more, and then it's back to not moving at all. It's not like cogwheel where it's like hitching the whole way through it. Right? Cogwheel, I think of like a hitch motion. It's like click, 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 click. And that can be for any motion, right? I could have lead pipe to the shoulder where you're trying to flex me and I don't move anywhere. Or I could have cogwheel of the shoulder where it's like click, 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 like I'm a robot. Do those two make sense? Okay. Versus spasticity is where the muscle itself is kind of going in spasms as I'm moving them through the motion, right? It could spasm in the opposite direction, could spasm in the same direction. It's not like rigidity, which is just kind of a fixed hard block. And again, it doesn't have to deal with bony end fields. Don't get that confused, right? End fields are totally different than this. This is just how the movement feels. If a patient has difficulty initiating movement, well, rhythmic initiation would be good for them, right? Motor planning deficits, where they have apraxia or dyspraxia, because rhythmic initiation is going to build that motor plan. Motor learning deficits, communication deficits, aphasia. What is aphasia? A meaning what?
Without speech?
Without speech, yeah, right? Don't get that confused with this other term. Where is my cursor not working? Oops, that's an H. Aphasia. Does anyone know what aphasia is? I erase this real quick because I.
When you replace words with the wrong word.
Nope. Good guess, though. It's a pretty fine guess. So this is my way of remembering these two, because when you're going to get a board question, these will confuse you. Aphasia has an S, so it's speech. Aphasia has a G for gut. This is difficulty swallowing. And if you're swallowing, it's going to your gut, right? That was my way of remembering these. And again, this is kind of off the topic, but when I see things like this, that's a teaching moment. I want to use it as much as possible. So aphasia is difficulty speaking. Technically, I don't like using this term aphasia, because aphasia literally means no speech. If I wanted to say difficulty with speech, I would say what?
Dysphagia?
Dysphagia. Yeah, good, right? But for whatever reason, when it comes to neuro, we kind of just throw that out the window and they call it aphasia or aphasia instead of dysphagia and dysphagia. Don't ask me why, because reasons. That's all I can give you on that one. And like, I don't remember if Diana had asked us in this class or if it was in that review session. I think it was in the review session. She had asked about, well, what happens if you have a patient that's got dementia or something like that, or has kind of out of it? Well, rhythmic initiation would be good to do because they don't have to do anything. But if you started getting to that resistive motion, you're not doing any PNF with them because they're off in left field and you might get a flower pot thrown at your head or something, right? So be careful with that. You can do this with a patient that's kind of demented or maybe has a little bit of Alzheimer's or sundowner syndrome, something like that. You can do rhythmic initiation with them because you're doing all the work, right? But you start making them do some work and that can get a little challenging, right? Just imagine somebody is kind of out of it and doing it with you. All right, so reversal of antagonist involves stimulation of weak agonist pattern by first resisting a static or dynamic contraction of the antagonist pattern. It's also known as slow reversal. So if I start moving you out into D1 extension, D1 extension, D1 extension, if you are doing an antagonist pattern to that, what are you going to be doing?
Pushing into D1 flexion?
Yeah, right. So I'm moving you out like this, and I'm starting to move you passively, and you're pulling up and in. So I'm moving you down and out, and you're kind of pulling up and in. That's going to help trigger some of that reciprocal inhibition, right? And you're basically strengthening those antagonist muscles. It's a way to strengthen those antagonist muscles, right? There are holds at any time that you can add a hold to any of these techniques, right? The opposite, good, right? If you add a hold to any of these techniques, that hold just means that you're now adding maybe an isometric contraction at the end. So like if I do a slow reversal hold, while I'm moving you out and you're trying to pull me up in, we get out here to the end and I'm like, okay, pull against me. 3, 5, 4, 3, 2, 1, good. Now I start moving you up and in and you're pulling me down and out. So anytime you see kind of a hold on any of these PNF patterns, what I want you to think is isometric. There's an isometric contraction going on. It does seem a lot like MMT. You're exactly correct. Yeah, so the PTA is moving them a D1 extension while the patient is trying to pull up into D1 flexion. Yes, Amanda, you got it. And again, trying because you're going to move them through the motion. You want a submaximal contraction for them. You don't want them like yanking you up and across the body, if that makes sense. You want to still allow to be going out, but you're kind of getting them to fire the opposite direction. And it takes a little bit of practice with your patient to get that optimal flow. They'll get it though eventually if they have some cognition there. So why do we do this one? The main reason I do this technique is a patient that is having difficulty with maintaining that agonist-antagonist relationship, right? So that would be a patient that maybe has a little bit of ataxia, where the nerve conduction is not firing exactly 100%. Or, yeah, their posture, yep, exactly. Posture would be a good one to do this, yeah, right? So any of those type techniques would be a good idea. We can do it for limits and range of motion because we're going to get a little bit of a reciprocal inhibition firing off at the same time, but I don't typically do it. The other reason we'll do this is because doing this one will fatigue them quickly. Like this, the reversal of antagonists will fatigue them out quickly. It may even fatigue you out quickly. If you've got somebody, you've got, I don't know, trying to think of somebody I can use in as an example. You've got, what's that famous gymnast that's out right now? Simone, whatever her name is. You've got her on your table. She's got some strength in those legs and those arms. And you do reversal of antagonists on her, she's going to wear you out. Right? She's going to wear out too, but you're going to wear out probably faster than she is, to be honest. Is that her name? I will trust you on that. I just remember seeing a commercial. Simone Biles. There it is. Thank you, Kersey. I knew I had a name. I think there is a Debo Rivar as well, but Simone Biles is the one I was thinking of. She's from the Uber Eats commercial, isn't she? That's where I think I know her from. All right. So repeated contract, repeated stretch is going to be for mobility. The patient is going to do a repeated isotonic contraction from a length and range induced by quick stretches. This is that quick stretch technique that I was talking about. So this is that one where I kind of go out, I pop that joint to bring them up and across, and then I bring them up and across, and I pop up and across to fire them down and out. And then once I get down and out, I pop them up and across and pop them down and out. And I do that kind of repeated kind of quick stretch technique to allow them to go into a repeated contraction, right? So if I am causing a quick stretch of the muscles, what reflex am I firing off of? The muscle spindles, good.
Myostatic.
The myotatic. Remember, there's no S. Myotatic. Yes, it's totally like I always think either myostatic or myotactic are my two misspellings that I do the most frequently with it, so don't feel bad. I've been doing this since forever, and I still spell that one wrong. So with that one, it could be from impaired strength, help initiate movement, fatigue, or limitation in the active range of motion, because when I get those firing off, I can get a little bit more range of motion. This is one that I will say, and I kind of mentioned this briefly in that review class, this one takes skill. And the reason I say it takes skill is because you have to know how much is just enough. Hiccup, sorry. And then to make sure that you don't go too far and do too much, right? So what if your PT says, hey, hey, I'm going to do some repeated contract, repeated stretch with this patient. Do you want to come help with it? You can say, sure, right? But make sure that you watch them a few times first and then have them guide you through it after that. We can still, this is a technique we can do, right? But you want to make sure that you have a trained eye helping you get through it the first couple times because it's really easy. Yep, no problem. So Riley, what this is saying is, so let's say I'm just going to use the D1 pattern because it's the easiest pattern to use here, right? So what's going to happen is I'm going to start in one direction. Doesn't matter which direction I start. I'm going to start going out in the D1 extension because that's the one I usually start with. So I'm going to take them out into that motion. And when I get to that terminal end range of motion, I like to call it, I'm going to pop them. And what I'm going to do is take them out into extreme range of motion way out there so that I trigger that maximal stretch of the biceps, the shoulder, even the forearm and stuff like that. So that those muscle spindles say, nope. And when that happens, what will happen is I'll pop that and it'll bring them up and across. Like a pop in the shoulder. Yep. Right. So I was down and out, boom. Right. And you can actually do this to yourself. If you're careful, do not dislocate your shoulder. Right. I can take this and go into that D1. And if I pop that out, I'm not doing that bringing back. That's literally just my arm doing the motion. I'm just completely relaxing my arm when I do that pop and I come up and across. So that's the repeated contract, is you're causing a stretch to cause that contraction. I can do the same thing. Usually I'm going to stick with one motion, Riley. So I'm going to be doing repeated contract, repeated stretch into D1, repeated contract into D1 flexion. But I could also just do the same thing where I bring it up and across the body and pop up here to cause me to go down and out. I don't like doing that one there because you let off. You don't let go. You never let go of their arm when you're doing these techniques. That's why we're going to have those nice lumbrical grips. When I get out there, I'm going to control it. Right. That's what I was going to say, Amanda. That's why I don't do a lot of D1 flexion, because it's really easy to pop them right in the face. So what I tend to do when I'm doing that is I have a technique for doing that where I keep my hand on the back of their palm so that when I do bring them up and across, I make sure I bring them way out here. But it's not a common technique. And again, that's one that definitely I had to take some courses to understand even how to do it. Because I'm like, well, how do I keep I'm almost punching myself in the face just doing the motions. How do I keep from punching my patient in the face? But the idea is you get that stretch, right? So let's say I'm doing D2 and I'm going up into flexion, right? If I just, and again, I'm going to relax my arm as soon as I do this pop, right? So watch what happens once I go up. That was not me doing that. I didn't trigger that. All that was is my bicep technically, most of it was my bicep firing off because I could feel it. My bicep saying, that's a nope sandwich dog. I'm bringing you back down and in. So again, when I'm going to demonstrate this one, we're probably not going to practice this one, Riley, because this is one that I would be more comfortable if you were working with your PTs in the clinic on. I will demonstrate so you see what it looks like, right? But this would be one that it would be okay for you, right, Riley? This would be one that you'd be okay in saying, hey, I'm kind of new at this. Can I watch you do it? Right? Can you show me how to do it? I am Missouri right now. I've become the show me state. Show me what you're doing, right? Especially on your 2-week clinical. Now, when you get to your later clinicals, you start feeling more confident, a little bit better about your skills. If you want to give it a try with the PT or the PTA right there, give it a shot. That's where I learned it the first time, was actually at an inpatient clinic, or an inpatient clinic, inpatient hospital. The PTA that I was with is like, hey, have you ever seen this with stroke patients? And I'm like, no. I said, I remember Dr. Borromeo talking about it, but I've never seen it done in real life. And she's like, come with me. Let's go. I want to show you. And she showed me it. And then I got on hands-on and started doing a little bit of it. And what she did is she would keep her hand back where she knew the range of motion was limited for the patient and say, I don't want you to go past here when you get that quick stretch. and it gave me a good idea to get the feel of that muscle. And then the more you get for a feel of the muscles themselves, the more you'll start understanding the technique. It is kind of scary though at first, right? And you know, when I do it to Anthony and Anthony cries, you guys will understand it. All right, so then we've got stabilizing reversals. Hey, Anthony volunteered for it. I don't know what's, I mean, motion is emotion, exactly. Stabilizing reversals uses alternating isotonic contractions of first the agonist and then the antagonist against resistance, allowing a very limited range of motion. The key to this one is that last phrase, very limited range of motion. Literally, when I'm doing stabilizing reversals, I may only have that much motion going on. Right? So I'm doing alternating concentric, eccentric, agonist, antagonist type motions. It's to build strength and stability of the joint. It's going to tie into the other two things we're going to talk about, which are alternating isometrics and rhythmic stabilization. So this is just a very small amount of motion. So resist, 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 resist. And I can't do it on myself. It'll be easier to demonstrate on each other, on a patient. But it's a very small window of motion that all I'm working on is maybe I'm working with, you know, I don't know. So I'm working with Brittany. Not necessarily like a two-manual muscle grade. It's more like I'm working with Brittany and she has some limits and stability when she's way up here in abduction and extreme flexion. So I'm only going to work on the PNF patterns out in this area where she's got that limit of stability in order to build stability in that small area. It's not going to build global strength. It's going to build stability in a limited range of motion. These two are by far my favorite activities, even though they're confusing. Alternating isometrics and rhythmic stabilization. So here's the way I remember these. When you hear alternating isometric, I want you to think linear patterns. I can do these with the PNFs as well, but I tend to do a lot of these in non-PNF positions, both alternate isometric and rhythmic state. Rhythmic stabilization noted here is a progression of alternating isometrics because now you're going to move in nonlinear patterns. When I say a linear pattern, what does that mean? What does a linear pattern mean? In a line, good. So I'm going to use core stability as my first example here, because then I can explain the extremities, because this is a good one for core strength. And if, you know, if John and Anthony go to the gym together sometime, they can really kind of do this on each other and actually see how difficult this is for core strength. So if I'm going to do alternating isometrics of the patient's core, I'm going to have them sit up nice and tall. I'm going to let them have their hands if they need it. Preferably, I'm going to have them cross their hands where they don't have handheld support. And what I would say, you know, let's say that I'm working with Christina. I'm saying, Christina, what I'm going to do, alternating isometrics first. I'm going to push you forward and backwards, straight line, right? Forwards and backwards. I don't want you to let me move you, right? So let's see if I can get Snicky down here as my example model, right? So I'm going to say, I'm going to push you forwards and I'm going to push you backwards. I don't want you to let me move you. And I'm just going to come and move you in a linear pattern. And your goal is to make a what type of contraction to stop me from moving you? Isometric, yeah, right? You're tightening up, holding that belly core. I could even do it in the neck like I'm doing here with Snecky's an excellent patient. Thank you for being my patient, Snecky. Right, I can do it of the neck too, right? And Snecky obviously needs to work on his stability because I can move his neck pretty good. I could go say, okay, Snecky, I'm going to push you left and I'm going to push you right. Don't let me move you. Dun, 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 dun. Again, linear patterns. I can go in diagonals as long as I'm staying in a line. So I could say, I'm going to move you that way and this way. Don't let me do it. Ooh, thinking about that, what type of muscles am I working there in those diagonals if I was doing the neck?
Is that like the triangle thing?
Step, scaling triangle, good.
Scaling triangle,
Yep. And SCM, yeah, right? Because if I'm going side to side, it's mainly traps, right? Traps and levator. But if I'm going kind of at these angles, that's a lot of scaling and a lot of SCM. It is perturbation, yes, right? Don't let me push you around. That is a perturbation, right? And Sneaky's eventually going to bite me if I keep doing that. So that's alternating isometrics, linear patterns. What do you think? So alternating isometrics, meaning that I'm going to push this way, you're going to hold. I'm going to push this way, you're going to hold nice and tight. Perturbating just means pushing, right? So if I walk up and I shove you, I gave you a perturbation. I didn't shove you to the floor. I perturbated you. All right. So now, all right, Mr. Snecky, now I'm going to make it challenging. What do you think the progression is of that?
It's not just backwards and forwards. It could be coming from any side.
Yes, very good. This is where I'm going to tell Snecky, hey, Snecky, I'm going to give you some pushes, and I'm not going to tell you which direction I'm coming from. That is rhythmic stabilization. I'm building a rhythm with his muscles of stabilizing. So I can come in and go tap, 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 tap. And I'm just kind of moving them all over the place until I see that he loses his ability to hold it. Then we're going to stop. He's going to restabilize, and I'm going to start again. Either of these. If you're pushing the patient and they're kind of floppy-dopping all around, that's when you got to stop and say, okay, recenter yourself, get your posture good. All right, hold it nice and tight. Let's start again. Because the goal is to hold that stabilization. This is why I describe it with the core first, and he is an excellent patient. Does that make sense at least so far? So alternate isometrics, linear, right, left, forward, back, diagonal, diagonal. Rhythmic stab, I'm banging you all over the place, and I'm not going to tell you. Which of those is going to require more stability?
Rhythmic stabilization.
Yeah, rhythmic stabilization by far, right? By far. So, does that make sense? So now, let me change it. Instead of talking about Snecky here, we're going to put Snecky away for a little bit in case I need him again. Let's add a patient that's got rotator cuff instability. Do you have a question, Stephanie?
Oh, shoot. Sorry. No.
Okay, just making sure. I saw. It lets me know when you guys unmute in case you have questions. So let's talk. I've got rotator cuff instability. What I could do with these techniques is I could tell you, like, let's, today I'm working with Joe, and Joe's got rotator cuff instability on his right side. I can have him lie on his back and hold his arms straight out in front of him. And I can start with alternating isometrics, where I tell him, I'm going to push your hand to the feet and to the head like that. Don't let me move you. He's got to lock in that rotator cuff and resist me moving him. Right? I could take it further and move him into kind of a push-up plus position where he's got those, which muscle locked in when I'm way out like this? I forget which muscle this is again.
Serratus?
serratus, right? Or I've got serratus locked in. Now I've got a longer lever arm, right? And I could adjust it back. Maybe if I push out here, it's too hard, but if I come back here to his elbow, it's a little easier for him at first. So I can shorten that lever arm. I can lengthen the lever arm. I could put weight technically on this and make it harder for him, right? Because he's now got, what if I put a 5-pound weight on my wrist here? Now I've got to hold that up in the air as well as holding my weight in my arm. And then I'm going to say, okay, we've got the alternate isometrics down. Good job, Joe. Now we're going to move into the new technique. Yep, exactly. GTR is going to kick in a little bit for sure, right? It's going to keep me from moving all around. Now, Joe, what I'm going to say is, okay, hold your arm there. I'm not going to tell you the direction I'm coming from. I don't want you to let me move your arm. And I'm just going to willy-nilly flap his arm all around. Or perturbate. I'm not going to say I'm going to smack him, right? But I'm just going to be coming at all angles, just techniques all over the place. And I guarantee you do that with a patient, their arm's going to be going like this. I can do that with any joint. I can do that with an elbow in 90 degrees of flexion. I could do that with a hip where I'm up in flexion or I'm out in abduction. Any of those techniques work as long as I stay linear with alternating isometrics or perturbating all over the place with rhythmic stabilization. We're going to practice this when we get to the clinic and we start practicing our PNF. We're going to practice this primarily on the core because this is a really good core exercise. Right? If you think you've got a good solid core, have somebody do rhythmic stabilization on you. You'll realize your core is not as solid as you thought it is. Because, you know, especially if you're sitting kind of out here at the edge of the chair and they're kind of perturbating you all around, you're like, okay, I got this. I got this. I got this. Now, the big question I had from last semester's group was, well, when I'm doing this, how do I document this? Because how do I do it sets and reps? How do I typically do sets and time on this one? So I'll say that I did, you know, alternate isometric 3 by 15 seconds, right? Forward and backward. So that just meant that I went forward and backward with them or left and right, however I want to do it, right? You could do sets and reps. I just tend not to with this one. I just kind of document how long I did it for because I'll tell that way I can tell John, all right, John, we're going to do this for 30 seconds. You need to keep your core nice and tight. You need to keep your hip nice and tight. You need to keep your shoulder nice and tight. Yeah, this would be a neuromuscular. You're talking about neuromuscular re-ed. Is that what you're saying, Amanda?
Yes.
Yep, this would be a neuromuscular re-ed for sure. Right, which also means that it's better billing. Yeah, I do document the seconds too. Yeah, I would say that I'm doing for 3 times 15 seconds, 3 times 45 seconds, whatever I'm doing it. I guarantee the first time you do these with the patient, especially if you're doing shoulder or hip, it's going to be like more like 3 times 5 seconds because it's hard, especially rhythmic stabilization. It is hard to hold a hip or a shoulder in a solid lock position while somebody's shoving you around. And it will make your rotator cuff burn. Like holding that for that long isometric, it burns. And there are all kinds of challenges I could add to it. Could I, I'm working with Joe again, could I give him just a regular kind of kid's plastic ball to hold there? Sure. Now I'm not only working stabilization of the shoulder, but I'm also doing that kind of irradiation technique because I'm having him contract his fist out here, which may fire off all his forearm flexors, which may fire off a little bit of biceps, which may hold that shoulder up there in flexion more, which may fire off the delts, right? So there are all kinds of techniques we can do with this in addition to just banging the person around. I had one PT that liked to do this with shoulder patients where they would have them get down in push-up position and they would have them in the upwards push-up position and would do alternate isometrics in the upwards push-up position and then have them go down into the 2 or 3 inches off the ground chest push-up position and do the same thing. Now he's working with high-end athletes, right? That's not something you're going to do with, Bob, the 65-year-old welder. But yeah, these are the athletes get kind of cocky when you're working with them. They're like, oh, I've got this. And you make them do that. And all of a sudden they're like, I don't like you, Mr. Physical Therapist or Mrs. Physical Therapist or Physical Therapist Assistant. It's really easy to kind of humble an athlete if you really want to. Do those two make sense? Let's finish with agonist reversal, and then we'll take a break here, because this is the last kind of strengthening technique. Then we're going to talk about stretching techniques. So agonist reversal, are also called combination of isotonics, is a controlled mobility skill technique. Remember, skill is the last thing we're going to develop. We're going to develop stability, right? We're going to develop mobility. Then we're going to develop stable mobile, right? Stability with mobility. And then we're going to develop skill. Does that make that process kind of make sense to you guys? So first I'm going to get stable, and then I can get mobile a little bit more. And then I'm going to get stable while I'm mobile. And then I'm going to start developing skill. Isn't that the way you guys learned how to do sports, or even like playing piano or anything like that, right? Think about the first time. How many of you guys have ever played an instrument before? A couple of you, right? Think about the first time that you played that instrument and how kind of choppy and hard it was to play whatever instrument. Like drums, I remember when I played drums, I had death grips on those sticks. I'm just like, Annabelle pound drums, right? And then I got a little bit fancier and I started developing some mobility with the sticks. I'm like, okay, I got this. And then I realized that if I have too much mobility, I might cause too much of a hit on the hi-hat. So I had to learn how to get stability with that hit and mobility, right? And then I got skilled, because then I could do it without even thinking, right? I can move through and I can't do that anymore. I suck at playing drums now. So this one is going to build skill, right? This is resisted concentric contraction of the agonist muscles through the range of motion is followed by a stabilizing contraction, holding in the position, and then an eccentric contraction in the other motion. So I'm going to pull you up and in. All right, so I'm gonna provide some resistance as you pull me up and in. And then you're gonna pull, so like, let's say that Amanda's my PTA. Agonist reversal is not causing motion of the muscle. What do you mean by that, Diana? Just so that didn't make sense.
Sorry. Yeah, sorry. I'm thinking of how to like word it. I'll get back to you. Sorry.
Okay. Maybe if I explain it here, it might help you understand it a little bit. Hold on one second here. I'll have to plug these in on break. All right. So if Amanda is my PTA and she's working with me, and we're going to start with, so what she's going to say is, you're going to pull me up and in. I'm going to pull you down and out. And what I want you to do is, when you pull me up and in, you're going to resist me pulling you down and out. So my concentric is this way, and then my eccentric is resisting her pulling me out. And then my concentric is this way, and my eccentric is resisting her pulling me out. That's a little different than the last kind of eccentric we did, where it was eccentric the whole way, right? She was pulling me down and out, and I was resisting. She's pulling me up and in, and I was resisting. So this time I'm getting a concentric contraction up and in, and eccentric contraction down and out. Or I could get a concentric down and out and an eccentric up and in. Did I lose anybody? I did lose somebody? Okay. So again, I'm going to use John as an example. So John is my PTA. I'm going to be the patient. John says, we're going to do D2 flexion and extension. Okay, so he shows me the pattern. This is what we're going to do. And he's going to say to me, what I want you to do, Mr. McKeever, is I want you to push me up and out. So that is my concentric phase. Does that make sense? That would be a concentric, right? Okay. And then I'm going to pull you down and in, and you're going to resist me pulling you down and in. That would be an eccentric phase. because I'm resisting him pulling me down and in. Keyword resist, yeah. So push and resist. Push and resist,
So
right?
the patient is going into the concentric movement on their own, and then you're resisting the eccentric movement.
Close, really close. So when the patient is going, so when whichever direction I do the concentric movement, whether it's up and out or down and in, whichever it may be, or maybe let's get away from PNF for a second. Let's just talk shoulder flexion and extension. Let's make it really simple, right? Just bare bones simple, because we could do this with flexion and extension too. So you're going to tell me you're going to move yourself up into flexion. I'm going to provide you some resistance going up in, right? So you're going to provide me with a little bit of resistance and then build that resistance as I get stronger. And then you're going to tell me, okay, I'm going to pull you into extension. Don't let me do it. And I'm going to resist you pulling me back into extension. And you're like, okay, pull yourself back up. Pull, 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 pull hard. Okay, good. Here we go. I'm pulling you out. Don't let me pull 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 you out. All right, pull it back up. Pull it up, 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 up. Don't let me pull you out. Don't let me pull you out. Don't let me pull you out. So I'm doing one motion where I'm getting concentric resistance. There is resistance in both motions, right? It's just one is a concentric resistance and the other is an eccentric resistance. Because one is me doing the motion, the other is me resisting the motion, which is what an eccentric motion is. Right? So like if I'm doing eccentric bicep curls, right? My eccentric bicep curls are me slowing down and not letting the biceps drop those weights, right? Same idea here. You're resisting me from pulling you out. Did that help clear it up a little bit more? Or is it now still clear as mud? Do we want to take a break and come back to it? The brain's fried. Okay, Diana says, yeah, much better. Okay, so let's see. I'm going to stop sharing here real quick. Stop sharing. Why am I stopping sharing? Okay, I'm going to pause. So we are back from break. And so we had one of the students ask to just go ahead and summon. We're going to summon demons or something. We're going to summarize agonist reversal again. So agonist reversal is a concentric contraction in one direction, followed by an eccentric contraction in the opposite direction. So you're going to provide resistance one way, and they're technically going to provide resistance the other, technically, right? So again, let's just use wrist flexion and extension as an example here. So flexion and extension. If I was going to do an agonist reversal of wrist flexion extension, I would say, all right, I'm going to have you pull up into wrist flexion as hard as you can. I'm going to give you some resistance. Pull me as hard as you can. And then I'm going to push you out into extension. Don't let me push you out into extension. So then I'm going to pull, and then the therapist will push, and I'm going to resist that push. And I'm going to pull, and the therapist is going to pull, and I'm going to resist that with a little bit of my own pull. Pull. So I'm getting, when the therapist is pulling me out, that is my eccentric component, because as I'm getting pulled this way, I'm pushing into flexion. I'm trying to slow that extension down. And again, eccentric is that slowing down motion. Does that make sense or help a little bit more? Make it as clear as mud, right? You can even do this technically with posture as well, because I could pull into flexion, right? Tighten my core up, and then you could pull me into extension, and I could resist your pull into extension. And then I could pull myself back into flexion, and you push me back into extension, and I resist that. All right. excuse me. So more techniques, yet more techniques. Hold, relax. A hold, relax technique. Now we're starting to get into more of the stretching type techniques. We talked about a few of these a couple days ago. We had done stretching a long time ago and Land Far, Far Away, talked about stretching. So this is a stretch technique. And stretch would be to improve mobility, obviously. Right? So the extremity is first moved to the point of limitation of the agonist. So for example, if my problem is I don't have enough shoulder flexion, so my extensors are limiting me and I can only get to 90 degrees, you're going to move me to my end field, to my where I can't go any further. At that point, I am going to perform a strong isometric, no movement, contraction of the antagonist that is restricted. So if I'm going to shoulder flexion, it's my lats and posterior delt that are resisting me. So I'm going to pull into extension. I'm going to resist you so you don't move. You get an isometric hold there. We're going to hold for a couple seconds. We're going to count it out loud. Okay, hold for me, Bianca. 5, 4, 3, 2, 1. And relax. And then I'm going to move you a little bit further into flexion and gain a little bit range of motion. We're going to stretch you a little bit further. And then once I get that new range of motion, I'm going to do the same thing again. I'm going to say, okay, push down again. 5, 4, 3, 2, 1, and relax. And I'm going to move you a little bit further into shoulder flexion. And I'm going to hold that for a few seconds, maybe 15, 20 seconds. And then we're just going to keep doing that as many reps as I can until I stop gaining motion. Or until maybe I have the PT is ordered to do 5 reps of those or something like that. So a hold, relax, like I said, a hold, relax is always got an isometric. When you see a hold, relax, that means there's an isometric contraction going on. So that would be the hold, relaxed. The next technique that we have, just moving some things around here real quick, is the hold, relax, active contraction. So at that point, it's what it's saying here is like above, except that the movement into the agonist range of motion is actively achieved, not passively. So what that's saying is, same idea. If I'm limited in flexion, you're going to get me to my range of motion limit. You're going to have my antagonist contract. So you're going to have me push down into you. 5, 4, 3, 2, 1. And then you're going to have me move into the new range of motion and then stretch me out there. So you're going to let me do an agonist contraction at the end of that hold, so that I get a little bit of reciprocal inhibition firing. So when I start firing that agonist, my antagonist relaxes to help with that relaxation. So a hold, relax, go to the end range of motion. You have an antagonist fire in an isometric manner, 5, 4, 3, 2, 1, and then I stretch you into a new range of motion. And then repeat, wash, rinse, and repeat. Hold, relax, active, or rack 1. I'm now going to do that isometric contraction, but now instead of passively being moved into a new range of motion, I'm going to actively try to gain some range of motion, and then you're going to stretch me at that new range. And again, isometric, I'm going to actively contract. You're going to come with me and hold me out there. Active contract, you're going to come with me and hold me out there. All of those are going to eventually have a stretch hold, not a contraction hold, a stretch hold where you're holding me into that new range of motion to gain range of motion. So I'm going to try using my finger here as an example, right? So I'm going to find out where my extension limit is on my finger. So right there's my extension limit. If I'm doing hold, relax, what I'm going to do is I'm going to get to that limit, and then I'm going to push into flexion because that's the agonist contraction. or antagonist contraction. I'm going to push, but I'm not going to let any motion occur. 5, 4, 3, 2, 1. I'm going to relax, and then I'm going to move and gain range of motion. That is hold, relax. Hold, relax, active contraction. I'm going to do a similar thing, find my end range of motion. I'm going to do that isometric eccentric contraction, 5, 4, 3, 2, 1. And then I'm going to try to move it. I can't really move any further. You would hold at the new range of motion. Yes, John. Each time you gain a little bit of range of motion, you're going to hold for a short period of time to get that nice slow and low hold out there and try to maintain that new range of motion. So those are two different types of stretching that we have for this.
So hold, relax is stretch passively after the contraction, and the hold, relax, active contraction is actively, the patient is actively going into the motion.
Yeah, they're going to try to
after the
actively
contraction.
pull into that contract. Yep,
Got
you got it. You got it. And go over here. There we are. And then we have contract, relax. So notice the key word that's missing out of these now. There is no hold. Now, instead of doing a isometric antagonist motion, they are going to do a concentric or an isotonic contraction. So that means you're going to allow them motion. So again, if I'm going to my finger, right? So if I was doing the hold, relax, I'm not going to allow any motion when I'm pushing down into flexion. If I'm doing contract, relax, I'm still going to provide resistance, but I'm going to allow them to push down into flexion. Get some isotonic going, 5, 4, 3, 2, 1, relax, and then I'm going to move. And then I'm going to get them out here to the new range of motion, and I'm going to hold, stretch it out. Okay, good, good, good. 15 seconds has passed. All right, let's contract again. Push down, push down, push down, push down, push down, push down, push down. 4, 3, 2, 1, and relax. And I'm going to move back into that new range of motion. And each time that I gain that new range of motion, I'm going to hold there for a short period of time in order to use that new range of motion. So hold, relax is an isometric. Contract, relax, we get an isotonic, a motion going. And then contract, relax, or what I call the crack contractions, or crack stretching, same idea. I'm going to allow that isotonic contraction to occur. And then when I want to gain the new motion, the patient's going to actively move themselves into it. So it's exactly like them. Yes, but an agonist reversal is, so agonist reversal, John, is a strengthening technique, whereas this is a stretching technique. Be pretty similar though. Right, so this, yeah, right. So that agonist reversal is more of a strengthening, this is more of a stretching. And yes, so with the contract, relax, active contraction, we're gonna have them move actively into that new range of motion until they get to the end where they can't move anymore, then we're gonna hold them again. And then contract, 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 relax, and pull it up. Okay, good. Now hold it there. And we're gonna hold. Okay, that finger's starting to feel kind of loosey-goosey. So the only difference between a hold, relax, and contract, relax, and a hold, relax, agonist, contract, and a contract, relax, agonist, contract is who is doing that final movement into the new range of motion. If it says active contract, that means the patient is going to move into that new range of motion. You're just going to hold at the end. Yes. Yeah, Anthony, so PROM versus AROM. That makes more sense, right? Yes, but also remember that when we really talk about range of motion, we're not stretching, right? But yes, you could think of it that way. Because remember, with range of motion, we're going to end field to end field. We're not actually stretching, right? But yes, you could think of it that way, right? So one would be like the contract, relax, and the hold, relax would be passive. And the contract, relax, active, contract, and hold, relax, active, contract would be active motion. Yes. You just have to be careful when you talk about stuff like that, because remember, passive range of motion, I'm just going to the end feel and stopping and coming back, right? I'm not actually stretching into it. Stretching is where we stretch into it. So it's not wrong, just not 100% right. Okay. So then we have, I think these are the last two, if I remember correctly. Yeah, these are the last two. Agonist contract. And I want to add on here because one of the other, I don't have this up here. Actually, no, because we just did antagonist, never mind. So agonist contract is kind of the opposite of the other ones, because now instead of contracting the antagonist right away, we're going to contract the agonist right away. So let's say shoulder flexion, again, is my limit. I can't get into shoulder flexion. My agonist is my anterior delt and my biceps, right? That's the one moving me into it. My antagonist, posterior delt, a little bit of triceps and lats. With an agonist contract, I'm going to go to where I'm limited. And at the point that I'm limited, I'm going to fire off on a contraction of that muscle, of the actual agonist. The muscle moved me up there. So my anterior delt, I'm going to fire that, provide a little bit of resistance, let them move till they get to the point where they can't move anymore. And then you're going to tell them to relax, and then you're going to stretch them. So the only difference here is they're firing their agonist off right away, and there's no firing of that antagonist. So agonist contract, they're just firing off that agonist. They're not even going to worry about the antagonist at that point. A lot of times with this one, a lot of clinicians get this messed up with some of the other strengthening techniques. So like, well, they're agonists. Blah, blah. You are working on reciprocal inhibition. You are 100% right, Diana. So Truman asked, if they reach the limit of range motion before they fire in the agonist muscle, does it move further? Not typically. So that's why you got to let them fire before. So what I would do, like if I was working with you, Truman, I'd be like, okay, Truman, let's move you through that range of motion. Where do you feel that hitching at? Well, I'm stuck here. So I'm like, oh, okay, so you're at 110 degrees, right? I'm going to back you off a little bit, maybe 20 to 30 degrees. And I'm going to say, okay, let's pull up to that range of motion. Pull, 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 pull. Okay, I can't go anymore. Okay, relax. And I'm going to flip my hand over and stretch you then. So that's working on that reciprocal inhibition, like Diana said. That's a pure reciprocal inhibition stretch. And like I was getting ready to say, is a lot of therapists really confuse this with the slow reversals and that. And so then they aren't doing this technically as a stretch. If you are doing true agonist contract, this is a stretching technique. So that means you're going to have a low and slow hold at the end of it. But this is probably one that most clinicians screw up the most. They call it agonist contract. What they're really doing is either dynamic reversals or slow reversals. So you just have to be careful when you're doing this, because again, with the strengthening techniques, there's no typical hold on them. They're just moving through the motion strengthening, right? With this one, I'm going to get to a range of motion and I'm going to hold it there, and I'm going to try to keep that motion out there so those muscle fibers tear a little bit so that I can stretch it out, because that's what we're doing when we're stretching, is tearing our fibers a little bit. Okay. So this one, I don't like this one, and I don't believe, so here's, I'm trying to approach this without being negative here, because this technique to me, hold, relax, agonist, contract, is really nothing different than going back a page and talking about contract, relax, agonist, contract. Really, or actually it's no different than hold, relax, agonist, contract. The main difference, and this is the book definition. So the main difference that when you're in a PT related PNF course for this, so the way the book says to do this is exactly like the hold, relax, agonist, contract. So I get to my range of motion, I do an isometric pull of the antagonist, I relax, I do a concentric pull of the agonist, I relax and I stretch. That's what the book says. By what the PNF techniques teach you for this one, you're doing a concentric contraction of both. So you're going to do a concentric contraction of the antagonist, followed by a concentric contraction of the agonist, and then you're going to relax. I can tell you pretty much with certainty, this one is not going to be on your boards. And there's a reason for that. And that is because no one agrees on it. When I was doing item writing, this is one that we argued with about like 15 times. Because to me, this is no different than a hold, relax, active contraction by the definition. And again, like I said, in the actual training, instead of doing, because here it says that, let me erase this real quick. Here it says by the book that you're doing an isometric contraction of the antagonist, but in the training, we do an isotonic or a concentric contraction. So this is one that I don't want you to worry about heavily. Know that it exists, but this is definitely one, you know, if I'm looking at like Amanda and I'm looking at Riley here who are going, well, then why are you talking about this, Mr. McKeever? Because you have to know that it exists. They're not typically going to ask you, and I can almost guarantee they're not going to ask you a question about it. Because again, no one agrees on exactly what this technique is. This is kind of like the black sheep of the PNF family that nobody seems to want to agree with which is which. Does that make sense? So don't totally freak out about it. That's right. That's a way to think about it, Amanda. After you pass the boards and you take a PNF course, you can then become one of the people that argues which it is. How's that sound? You can jump on my camp and say that it's a concentric and non-isometric, and you'll be right. Or you can jump on the book's camp and be wrong. Just kidding. I would never say that about the books. But all of those last couple techniques, all the way going back to back here to hold, relax, and a contract, relax, and then these two are all your stretching techniques for PNF. So most of the PNF, and I divided this up specifically on your lecture to show that there are strengthening techniques, and then there are stretching techniques. And again, I'm going to add, these are not all of the PNF stuff. This is all the PNF stuff you kind of have to, I know. This is all the PNF stuff you kind of have to have an idea for your boards, but this is still not even, like this is a 10th of the PNF stuff if you want to become PNF certified. Okay. Brains fried? Stability, technique, strengthening and mobility. Yes, there you go. That would be a way to. Now, again, you could also have controlled mobility, which has stability to it, Amanda, right? Controlled mobility is like stable and mobile at the same time. Right, so I like to think of, when I think of controlled mobility, at least from my standpoint, I think of, oh my God, why am I drawing a blank? Tai Chi. Right, because Tai Chi is a very slow flowing movement, but they're in very much control of their movement. Right, that would be what I think of controlled mobility kind of idea. Because I relate everything kind of back to the martial arts just because that's the way my brain works, and I apologize. And you're going to get a good hammering of martial arts type stuff when we go to lab, because some of the stuff just makes more sense if I discuss it from a martial arts standpoint. But yes, stability techniques are strengthening. Typically, mobility is typically stretching, or passive range of motion, right, where we're just trying to keep it.